Welcome back to Power Breakfast. Now, the Pan-African Cleft Lip and Cleft Palate Scientific Congress program has been taking place for the past couple of days. So today, when we talk about health tips, we're going to be discussing cleft lip and cleft palate, what the facial and oral malfunctions are all about, and familiarizing ourselves a little bit more with that. I have Dr. Meshack Onguti, who is a reconstructive surgeon and also executive secretary of the Congress program that I've just mentioned. Welcome to Power Breakfast.
Thank you. Good morning.
So let's first begin to familiarize ourselves with what cleft lip and cleft palate actually are. A lot of people kind of use those interchangeably. Maybe you can talk to us about what the difference between the two is.
Thank you. Cleft lip and cleft palate, basically what they mean that when you talk about the lip, it is something that has gone wrong with the lip. And the lip, this is the external part of the mouth. Mm-hmm. And when you talk about the palate is the inside of the mouth, where you have where the teeth come from. So when you talk about a cleft means that there is a division, there is a gap that occurs in places. And there are many clefts in various places. Right on the top, some of the clefts are normal, mm-hmm. and they do the normal things. For example, that you can't go to the toilet if you didn't have a cleft, would you call that an area, for example, and many other areas. But in the case of the mouth, what happens that when a child is born, there's a gap. The tissues from the two sides don't join together in the middle. Okay. And as a result of that, you have a problem. Or the two sides of the palate, as they grow towards the center, they don't join and make a gap, mm-hmm. which means that somebody can look through the mouth and see the nostrils and see everything else. Right. And the reason why this is so significant is that, you know, the mouth plays a very major role, the lips, for example. In terms of eating, you can't swallow if your lips are open. Mm-hmm. In terms of speech, in terms of appearances, because
dental issues.
Yes, because mm-hmm. people are recognized by how they look like. Yeah. So anything that occurs here that's why it's so significant. Mm-hmm. And so cleft lip and cleft palate simply means a gap or a defect mm-hmm. on the lips and on the palate.
So let's talk how early they are detectable or diagnosis.
Yes.
At which point does that happen in children?
Now, in areas like in Africa, most of the children are diagnosed at birth. When the mother is giving birth, then they find that, oh, they are giving birth to a child who has got these deformities. But in higher centers or in the Western world, where there is good investigative, like ultrasounds, they can be picked up at about 3 months or between 2, 3, and 6 months into when the child is still in the womb, during pregnancy. Mm-hmm. The only thing that you only know that, yes, I'm actually carrying a child who could be having a cleft or cleft palate at the moment. Nothing can be done with mm-hmm. In most cases on. Yeah. So, but as time is going by, we're actually becoming more and more more sure that we can diagnose this as early as 3 months without any difficulties at all, because the face develops mm-hmm. In the first 6 to 10 weeks. Yeah. The face has developed. Yeah. So beyond that, it's basically growing and making out the structures they grow along with it. So for a diagnosis that is made that early during pregnancy, is there anything that can be done at that point to sort of not further the effects of the cleft lip? Now, there are two things that we have to. First of all, what causes clefts? Mm-hmm. What makes people have these clefts? And there are serious things that we look at in this particular aspect. One, there are mainly two main causes of clefts. One is genetic, whereby you will find that in that family there has been a history of people being born with a cleft. Okay. Right now, as I'll talk later on the conference we're having in Nairobi here, we did have a child whose the mother of the child had a cleft. Mm. So you find, but the incidence is very low. Mm-hmm. But the highest number is as a result of environmental factors, particularly malnutrition, because there are certain things that the cells require when they are growing, okay. so that they can be able to grow together and move nicely and join. Mm-hmm. And one of those things that is quite clear is, for example, folic acid, simple things, vitamin A, for example. In the rural areas where some of these things are quite common, you find these children, it is the mothers who are pregnant. Sometimes they don't know they are pregnant, particularly in the earlier stages, 1 month. So what happens? They think that maybe they're having, they feel like vomiting, they feel like so they don't eat. And as a result, that's a very critical time when the face is developing. So actually, they miss certain part of that. The other thing is basically, in the cities, there's a lot of pollution that is there. You've seen the smoke. A lady is pregnant at that particular stage, and you're passing on. There's a few could be in front that's mocking up everything, and the traffic is slow. You don't realize how much of that you're trying to do. The chemicals that we are talking about. And then there are drugs also. People, for example, who have got epilepsy, you will go to a doctor and say, I'm having headaches, I'm having these things. And then you say, look, maybe you could be having a problem. And we'll prescribe certain drugs. These drugs can also have that effect. But so in one way or the other, we can basically be able to, if we knew that in that particular region, we can actually be able to prevent this by asking the mothers to begin taking folic acid, all of them together before, even 3 or 6 months before they plan to get pregnant.
As a preventative measure.
As a preventative measure, yes.
So, you've talked about some of the causes of this, environmental factors, malnutrition, etc. Maybe you can also touch on the stigma in communities where this condition is not really understood.
One of the reasons that why we pay so much attention to the care and of these children or adults, because there are areas where, if the example service are not available, you still have adults who are having clefts, is the stigma associated to it. Normally when these children are born, the first thing that the parents say is, look, what do we do here? They actually, because it's a shock to them, and a shock to the family, and they don't want that child to be seen by anybody. So from the word go, at birth, you find that it's causing a stress in the family itself. Number two, we as Africans sometimes, we believe a lot on juju and many other things, where they will say, look, the lady, where you've come from, you brought this to this home, So they start, actually, division starts at that time with the family. And the other aspect that you find is that the other people around, they look at it and say, they even begin telling the children, don't go there, there's a problem there. So automatically you actually begin separating those people from the community, from the public, and they hide those children, which means that those parents are not going to work, they're not going to do anything. In fact, they will do a 24-hour care of those children. And as a result, that means they don't become productive. And remember this way, this is a condition that can be fixed nicely, and these children will be able to grow up to be normal people, and they will be able to do anything that anybody else does, because this doesn't involve disturbance in the mental capabilities of these children, or the physical, except for the disfigurement that is supposed to be there. So that is there. And then the other thing that we also find here that, you see, certain communities that is dying out now, not only here in Kenya, but many all over the world. They sometimes could just leave these children die, because that's happened. But remember, these are alive. These are alive. And the other thing is that, you see, there's this question of insurances, saying that, look, clefts are unexisting. That they are congenital things, so they don't cover them up. So automatically, you are also adding more stress to it, because how will you feel, for example, that if we start segregating and actually abandoning children at birth, children who have nothing to do with it?
Horrible,
So the best thing that we really look, this is why it's so significant that, look, it is a disability that can be fixed, and there should be no way someone can say that they cannot cover these conditions at all.
What is the best case scenario for you as a reconstructive surgeon? How soon do you want to see this child? How soon do you want to start treatment? And just talk to us about that.
One thing that, obviously, these children are born at birth, and because of that, they will be having issues with the feeding, issues with the appearance. So we need first of all to see the children at birth when they have been born, and normally the pediatricians, the children's doctor, who will always see them and make sure that there's no another abnormality in the body, for example. Because normally when it's occur, it also has heart problems. Sometimes you find the fingers are fused together, or the feet are fused together. Not very common, but it does occur. So, but then we say that we let the child grow up a bit to about 3 months. And for the lips, we fix them anywhere between 2 and 3 months. We fix them at that age. Then, as time goes by, we will also be able to fix the palate that's before the child starts talking. That's about 7, 9, 10 months of life. The other thing that, so we follow them. The reason why I want to see them earlier and also is to reassure the parents that, look, these children are normal, they will be fixed. Take care of the feeding issues. Make sure that they go and have their normal vaccinations that are supposed to be there. And it's actually when we fix them up, it changes their lives completely, and you can see you see a burden being released from the families.
How many surgeries on average does it take for you to, as you're saying, fix them up?
So what happens is that because of the difficulties that sometimes we have got in terms of these children getting services in mainstream avenues, there are two ways. Sometimes we organize outreach programs where we go to an area and do as many cases as we can, so that we are able to do, and we do that. And like next month, we want to do one here in Nairobi at Mbagathi, so whereby we could be able to, because we had one in January, and there are many children that we didn't manage to perform, to take care. So we are going to plan one next month, so we can be able to help them out. So, but there are also other institutions where the expert is available to do these cases, so they can always go to that particular place. So the only thing is that, look, these children, they require the same care, the same attention like another thing. I know in the past we were more focused on infectious diseases, you know, things like malaria, things like TB and everything else. But this is also because when you look at the disability, what it will cost on someone's life, it's actually so nice you fix this up, because you are having someone living for over 60 years who's going to contribute to the economy at that particular moment. So that's why, yes.
Tell us about the Pan-African Cleft Lip and Cleft Palate Scientific Congress program, how long it's been taking place, what you have achieved in the years that you've done this.
Pan-African Association of Cleft Lip and Cleft Palate, it was mainly set up so that they can be able to focus on clefts a couple of years ago. But for the first time, we're having an international congress here in Nairobi that started on the 25th, mainly to bring attention of both the African governments, the African continent and the world, that, look, cleft care is now a major problem that we need to address. And the title, the theme of the conference was Shaping Up Cleft Care in Africa by setting up standards and protocols for better outcomes. And the reason that we want to ensure that these children get the best in terms of quality and safety of their work, and make sure that what we expect them to be as time goes by is what we achieve on. So, and you see, you can do this in two ways. One is to make sure that the people who take care of clefts, you train them in a way that they will be experts on this particular aspect. So for the first time in Africa, in Kenya here, we organized a pre-conference where we are streaming live surgeries from the operation room to the audience that are registered to be trained from all over Africa. We are actually 24 countries represented in Africa, and we are also people from UK, from France, from Netherlands, from the US, and from Bangladesh. Now, and the whole idea is that we needed to come out with certain protocols in terms of what it is. And it's so exciting to see in our own setup. Because sometimes we think that only the best things are done outside. But we have the capability and skill, and what we really need is a commitment of all of us as a team to work together. Because if we don't work as a team, then we can't make a difference. Because that's a fact of it. We don't make a difference if we don't work as a team.
And I think it's very important for people watching this to understand that that type of care is available in Kenya as we speak. You brought up the issue of insurance earlier on, and I'm sure cost is a major factor to any parent or potential parent who's watching this who might have a child who suffers from this, you know, sort of abnormality. How would you reassure that person that they can still come to, whether it's the clinics that you're saying that you're setting up and going to patients where they are?
One of the reasons when we realize this gap, that these people are not having the attention that's supposed to be there, there are many of us who volunteer and ensure that they give the services. So regardless whether there's no insurance, these children can still get the services. We have our association that take care of that. And I don't mind, for example, giving the number where they can be able to get the children. For example, if there's anybody who has a cleft lip and a cleft palate, and or in the past it was not done properly, they can come, and because we want them to look as normal as it can be.
Yeah, and that's the other thing. We've talked about children a lot, and maybe there might be adults as well.
There are many who were done before. Maybe at that time the technique, the skill was not as perfect as it is right now, and they would like to look as normal as possible. So in this aspect, the number they can call is 0719 555 665.
Okay.
And right now, maybe in the next 2 days, because of the conference, the numbers might be very busy, but thereafter they can be able to call thereafter, and they will be able to advise them where the help can be got.
Yeah, yes. And perhaps for someone who wants to maybe reach you directly, wants to come in and have some sort of consultation with you, can tell us where you're located? Yes,
we're here in Nairobi, actually the Hurlingham Park, A6. In Hanging Skodek Road. That's where they can be able to reach us, and we can be able to help them up.
Yeah.
Yes.
All right. Well, thank you so much for making time for us this morning and sharing with us the important work that you're doing. Hopefully someone watching today has changed their perception of cleft lip and cleft palates as well, and will understand that seeing you or a doctor as soon as possible is the first way towards treatment.
Thank you.
Thank you so much, Dr. Meshack Onguti, a reconstructive surgeon who's been talking to us about the program that he's engaged in, which is about spreading awareness and also understanding more about cleft lips and cleft palates. Thank you so much for watching Power Breakfast. We've got more coming for you after this short break. Willie Saburu will be joining us with his Man Cave panel, so don't go far.